do you believe LDN could one day serve as a frontline treatment for nociplastic pain conditions like fibromyalgia, potentially before trying SSRIs, SNRIs, or opioids? Why or why not?
I think it should. Should and will. Indirectly unrelated to the drug, I think that it's going to be a tough road to hoe, so to speak. I think there's a lot of politics around pain. There's a lot of financial things around pain. There's a lot of provider training that's lacking. I think it'll be hard. I think it should be the case. We get very little benefit from most of the standard treatments. Not that I don't utilize them when I have to. As I said, sometimes you have to buy time for people to get things down so that you can work in the background. But long-term benefit, like we didn't touch on things like opioid-induced hyperalgesia, which low-dose naltrexone can help ameliorate, right? So will it become that way? I doubt anytime soon. I think that there's just too much politics. I don't know, you're probably in this world more than I am, but from what I've seen in hospitals and clinics and other providers, I think that if anything, people are moving away from pain management and discontinuing service lines because of the high medical utilization and the complexity. And somebody else had mentioned, if it's not a linear path, they're not trained in the same way because it's a different level of intervention, so that makes it more difficult.
So I'm going to come from it from a very pharmacist, but also recognizing barriers. Number one, the entire oxycodone discussion, with that understanding that these drugs are not necessarily appropriate for chronic pain. That was the big takeaway, and we've seen a lot of questions now. We're seeing changes in actual standards of care and when they can initiate opioid drugs. And we're fighting against a very, very well-funded intention to use them, but now there's this pushback from the actual governing regulatory authorities that are saying we have to use these more sparingly, and certainly there's limits that we can use. So now all of a sudden prescribers and healthcare professionals are starting to say, what are our alternatives? So again, it's awareness, adoption, and then this sort of shift where people say we see benefit. And so that is where we are right now. We're at the inflection point of people are moving away from something and they don't know what else there is. And so you see it in, and certainly I'm sure all of you have seen, well, we're going to try, I don't know, red rice yeast as adjunct. We're going to try X. We're going to try, now we're getting into all sorts of different molecules and supplements, and they all have benefit. But if they're going to come back to the drug discussion, and then we can point to this evidence and this information and these case studies that are starting to build, more and more providers are starting to say, well, there's support for this. So before we touch opioids, here's some other molecules that we can use. Interestingly enough, GLP-1s are now being investigated for chronic pain as well as migraines, which is really, really, really neat because we see the overlapping function. And that seems to be the driver of conversation, is function to outcome. And so, yes, we're seeing that shift. The SSRIs are falling out of favor really quickly. We're seeing new molecules coming along. I think ketamine, psilocybin, there's other molecules out there. But naltrexone being one of these ones saying, look, we were getting some big health organizations, I believe the Harvard paper, they're the ones who said, hey, we can use this in conjunction with. And it, again, Malcolm Gladwell, Reverse Tipping Point, that's his new book. I have no financial interest in this book, but there's a specific chapter about getting at least a quorum of about 20% of your prescribers to change their mindset, and then all of a sudden you see this explosion of utilization. You infect the rest of the prescribing patterns of that facility when you have 20% of the people who are doing something one way, and then everyone will adopt it quickly. So we just have to get a positive infection rate of LDN prescribing into these different systems. So how's that for a weird one from a microbiologist? Positive infection rates.
And just in this discussion, it's just the argument for making it first-line treatment is The risk of harm is so small when you've got a meta-analysis of naltrexone that looks at all these studies, 11,000 subjects, and you've got 11 incidents, none of them of severe intensity. Nothing compares. And this is kind of going down a different alley. It's just anecdotally, my target is usually PTSD, mental health, anxiety, OCD, some mental health issue, but in those cases, often they're not expecting their pain to go away. I have a client with KFOS who, yeah, it's like, oh, most of his pain's gone now. He's standing up straighter, and that's just naltrexone. And then just on the patient being able to regulate it, the client with arthritis, rheumatoid arthritis with triplets, she found that 3 milligrams worked better for her than 4. I have another client with ankylosing spondylitis that if he was having a flare, he would move his normal 5 milligrams 2 or 3 times a day up to 10 milligrams, and that helped manage the flare better.